and welcome to this webinar. First of all, I express my deep condolence to the sad demise of all the health professionals, especially the doctors, who work in their working place in the world, and surely in our country. And we already have lost our 82 doctors. Among them, there are learned teachers, senior, junior colleagues, and friends and dears. Rest their soul peace in peace, and may Allah grant them in Janatul Firdaus. You know, COVID has affected in every part of our life, daily life, our practice, hospital life, but it has also opened up a new avenue and new windows, that is Zoom, where you can share our knowledge, exchange our views, and get a conference at all. So today's our topics is recurrent incisional hernia. You know, the management of hernia is very challenging to the surgeons, and especially you have to know the proper anatomy for doing the proper anatomy for doing the surgery. And for managing the hernia, we have to evaluate the patients preoperatively. We have to think about the patients of comorbidity, and preoperative evaluation is very important. And we can manage, there are so many ways how can we manage the incisional hernia by doing open laparoscopy, even laparotic procedure. And due to innovation of new techniques and bioprosthetic meshes, we are managing this hernia, but still the recurrence rate is not too much decline. Rather, new techniques applying created more complex hernia that is more difficult to manage. So the main focusing for regarding hernia management is the prevention. So prevention will be the main focusing in relation to hernia. So because abdominal wall is the unique in terms of functional anatomy. So for this reason, I like to introduce, there are so many experts, panelists, and our learned speakers here. I like to introduce our learned speaker, Professor Dr. Suresh Chandra Hori sir. Is Chief Consultant, General Laparoscopic and Bariatric Surgeons, Citizen Special Hospital, Hyderabad, India. He was past president of ASI, Association of Surgeons of India, in 2013, and past president of Association of Minimal Access Surgery of India, 2014 to 16. His keen interest in teaching and researching, and his special interest in perforating the mesh plastic in defined hernia. We have also expert panelist, Professor Samsul Alam sir. He was head of the Department of Surgery in Bangladesh Medical College and retired in 2019. He is present Secretary General in Hernia Society of Bangladesh. Professor P.K. Shah sir, he is advanced laparoscopic surgeon and ex-head of the Department of Surgery in Soysawadi Medical College Hospital. And now he's working at Somilita Hospital, and he's very, very positive and well-known surgeons in our country. We have also Professor Dr. Somiran Kumar Mandal sir, working in the Department of Surgery and Minimal Invasive Surgery Center in Pardon General Hospital. He is present General Secretary of Society of Endolaparoscopic Surgeons of Bangladesh. It's very eminent and expert laparoscopic surgeons. Dr. Mozammel Haq, Dr. Nurhassan Bhuiya Science sir. He's associate professor working in Department of Surgery in Cherang Medical College. He's present Secretary General of Society of Surgeons of Bangladesh. He's very enthusiastic and dynamic surgeons. Dr. Mahmoud Mozammel Haq, associate professor in Soysawadi Medical College Hospital, who is innovative and energetic surgeons. So welcome everyone, sir. I request our speaker, learned speaker, sir, Professor Suresh Hori sir, to start his presentation.
Good evening, sir. Adab, sir.
Good evening.
Sir. Asi, sir. Thank you very much for your participation. We will be enlightened for your essence. Thank you very much, sir. Thanks a lot.
Thank you. Suresh, Hari, okay, I'm Chini. I know.
Sir, welcome, sir. Osamatriun, sir.
Very good
Thank you.
afternoon.
Good.
Thank you.
Yes.
Senior surgeons, Bangladeshi surgeons, whom I love and adore a lot. I remember when I came as president of minimal access surgery to Bangladesh. I remember all the memories with all the senior surgeons and the time we spent with the laparoscopic surgeons of Bangladesh. My special thanks to Dr. Saha and Dr. Mamnoor. Today, I thought this webinar I wanted to dedicate to a topic which is a very important topic, especially on a subject which is a very simple subject. Incisional hernia is a very simple subject, but recurrences are the big problem in incisional hernia. So I thought I will dedicate my 20-25 minutes to this topic of recurrent incisional hernia. So you can actually see that Sir Cecil Wakely, who was the president of Royal College of Surgeons of England in 1948, said that a surgeon can do more for the community by operating on hernia cases and seeing that his recurrence rate is low than he can by operating on cases of malignant diseases. So one should not think that a surgeon who is doing malignancy is a big surgeon and a surgeon who is operating on hernia is a small surgeon. A surgeon operating on hernias does more service to the community if he sees to it that his recurrence rates are less. So the importance of maintaining a low recurrence rate is much more important to the community and to the surgeon himself than by operating on cancer cases. So that's the gist of this topic. Again, Lord Moynihan, a great surgeon, said, never judge the surgeon until you have seen him or her close the wound. Most of the senior surgeons today, they do a wonderful surgery, and at the end of it, they leave the closure of the wound to their postgraduates or to their DNB students or to their assistants. So that is the one which has been contributing to the high incidence of incisional hernias across the globe. So my gut feeling is you teach your assistant or your postgraduate how to close a wound properly. And if your assistant closes the wound properly, maybe the incidence of recurrent incision hernia is less. So how you do a good surgery is not very important, but how you close a wound is very, very important, especially in preventing recurrent incisional hernias. So coming to the incisional hernias per se, amongst the recurrences can be true recurrence, which is a failure of our surgery. Either it may be an open surgery in the form of an onlay or a sublay, or it can be a laparoscopic ventral hernia repair in the form of a intraperitoneal onlay mesh. Sometimes the recurrence may be because you have missed a defect during laparoscopic surgery or even in open surgery. I have seen even surgeons operating on obese patients, open surgery, come to me within 3-4 days with a missed defect producing a complication. So missed defect can also be a problem. Again, a new hernia can develop once you have done a very good laparoscopic or an open repair for a incisional hernia. A new hernia can develop. This can also be seen by the patient as a recurrence. Sometimes you get a pseudo recurrence, which is because of a protrusion of the mesh, especially when you use lightweight meshes, or if you don't close the defect in a hernia and put a mesh, the intra-abdominal pressure can push the mesh into the sac if you have not done a sac excision, and this can give rise to a pseudo recurrence. So coming to a few facts about incisional hernias, recurrences are not limited to the first 2 to 5 years. People have a tendency to think that the incisional hernias do recur in the first 2 years, but they can continue over a course of a follow-up right up to 15, 20, 25 or 30 years. I have seen my own patients whom I operated 30 years back with incisional hernia. Again, another important point, one should never take incisional hernia because are higher. If you do a third time, fourth time, the recurrence rates are much more higher than when you are operating on a first time incisional hernia. The one important point, which is that now is a world over, it is mandatory, is you have to use a mesh in ventral hernia repair. So, you should not think that I can do an anatomical closure for this and prevent a recurrence. Use of the mesh in ventral hernia repair is a compulsory in or in open hernia repair. The rate of the recurrences have reduced, but we have over the time, in spite of the newer technology and newer material, not become zero. We have not attained the perfect recurrence-free incisional hernia repair in spite of the multiple techniques and newer technology and newer measures which we have been seeing. You can see in this slide that the recurrence rates of the anatomical simple repair vary from somewhere between 50% to more than 50%, 55% in some patients. One should never ever do a hernia repair without a mesh, even if it is an open repair. On a sublay repair, again, also we have seen recurrence rates right up to 23%. Even in it's a certain repair, we are seeing in the early phases, especially in late 1900s and early 2000s, we have seen in small series where they have not done big numbers, recurrence rates right up to 17% in some centers and 1.6%. When a hernia recurs, we should actually anticipate not only anatomical and other issues where it is the surgeon who is responsible for the failure or recurrence of a hernia repair. The surgeon underestimates the extent of the hernia. If you see an obese patient who is around 100 kilos, he comes to you with a small epigastric hernia. You think it is a very small hernia, you underestimate the extent of the hernia, or you see a small infraumbilical hernia. But when you go in, when you start doing the surgery, it becomes a very difficult one. The sac is much, much bigger than what you have estimated. You are prepared going into the surgery by asking your company guys or your hospital guys to prepare a kit for a 10 by 15 mesh. But when you have gone inside, you have a huge defect, and your 10 by 15 mesh is not going to be sufficient, and you might need a 15 by 10, or you might need a 20 by 15 mesh in those cases. So you are sometimes responsible for failure of a incisional hernia repair, especially when you underestimate the extent of the hernia. If you don't understand the anatomy and physiology of the hernia, especially lateral hernias or infraumbilical hernias in a thin patient, then also you can get a recurrences. Especially if a surgeon does not have the proper skill or does not have a proper experience and his knowledge is limited, he is likely to end up in a recurrent incisional hernia. Patient issues are also there. It is not the surgeon who is at the fault all the time. There are certain patient habits and patient profiles which will give rise to recurrences, especially if you operate on a B.M.I more than 35 patient, or in some patients who have genetic issues and collagen disorders where there is a defective collagen production. Whatever you do, how many times you do an anatomical repair, these patients come back to you with a recurrence. And one point which you should definitely remember, in some areas where smoking is a very big issue, is you have to stop the patient to smoking for 3 weeks before surgery. If you don't do this, and if you operate on a patient without stopping smoking, your recurrence rates will definitely must be very high. And if you are operating on a wound where there is an infection, and if you have not properly controlled the wound and you operate on that patient with sepsis, then your recurrence rates are again very high. Again, if you get a patient with intestinal obstruction, with the hernia, and there are bowels in the sac, it is not an acute intestinal obstruction, it is a subacute intestinal obstruction, and you tend to operate on the patient without preparing the patient preoperatively. Sometimes you can take 3 days to prepare these patients, do a good bowel wash, do a good bowel preparation, and take up this patient for surgery. Your incidence of recurrence rates will definitely be lower. And even in these patients, if you do a good preoperative preparation, bowel preparation, inadvertently, even if you open the bowel, you can repair the bowel and put a mesh. But if you operate without preparing the patient, without doing a bowel preparation, and you do an inadvertent enterotomy, there will be a leakage, there will be a seepage of the bowel contents, and you are putting a mesh may give rise to a lot of complications. And you may not have to put a mesh in those scenarios if you don't prepare your patient preoperatively. If you have not controlled diabetes, if you have not controlled other issues, renal issues and other issues preoperatively, your incidence of hernia will be higher. Intraoperative issues, if you pick up a small mesh, earlier in the early 2000s and late 1900s, we were using a small mesh, maybe 2 to 3 centimeters bigger than the defect. And without defect closure, people were attempting to put the meshes. These give rise to lot of recurrences. And if you have not properly fixed the mesh, or if you have not given a proper overlap of the mesh, then also you can give rise to a lot of recurrences. Again, as I told you, if you are operating on a patient with intestinal obstruction and there is a tension on the repair of the defect which you have done, that can also give rise to incisional hernias. Inadequate exposure of the area where you are putting the mesh, inadequate dissection of the area where you are going to put the mesh. These issues also, as we go along, I will discuss these issues. And overlook multiple defects, especially if the lot of momentum is adherent to the scar and you only try to do that area, that defect which you have seen from outside, and you have overlooked the other defects. If you have not done the complete dissection of the adhesions, you will be overlooking multiple defects, Swiss cheese defects. This can give rise to hernias in future, and that can give rise to recurrence. Again, always open surgery with onlay mesh give rise to a lot of recurrences than with laparoscopic hernia repairs. If the fascia is not strong, if it is a woman whose tissue is not strong enough and you have not used a mesh, definitely you are likely to get a recurrence. If it is a lower abdominal defect or a lateral defect, we have failed to fix the mesh at the iliac crest or below the pubis, then you will get lower abdominal, lower incisional defects in recurrences in these patients. Again, as I told you, if you have not done a proper release of adhesions, or you are closing the defect by using rapidly absorbable suture material, not using a non-absorbable suture material, this can also give rise to recurrences. Sometimes if you again close the defect when it is under tension, the sutures can break or the tissue can tear. This can also give rise to recurrences. Bowel injury, as I told you, if you have not prepared the patient properly, a bowel injury during surgery can give rise to infection, sepsis, and that can give rise to recurrences. If it is a huge defect and you have not done a proper component separation technique, you are trying to close the defect very tightly by approximation, this can cut through and can give rise to an incisional hernia recurrences. So this is one picture of a patient whom you can see a suture pack which has been used to close the defect without mesh, and you can see a recurrence, huge big recurrence in this patient. So however strong the suture material may be, if you have done a suture repair without mesh, it will definitely end up in a recurrence. Sometimes people tend to use proline mesh in intraperitoneal onlay repair. This should not be done because this will give rise to dense adhesions and there will be a huge big hernia. And once you try to open, all the bowel is stuck to your proline mesh. You should never use proline mesh in laparoscopic hernia repair. Sometimes people use open technique where their peritoneum is thin and they think, okay, I am using a proline mesh. I have seen a lot of open repairs also where the bowel is stuck to the mesh, proline mesh, where the peritoneum is very, very thin. Some people do not have a thick peritoneum or fat in the peritoneum. They have a very thin peritoneum. If you try to do an E-tape or EAR in these patients, you will be producing a lot of multiple defects in the peritoneum, multiple injuries to the peritoneum in these patients. So a lot of people do have thin peritoneum, and in thin peritoneum, if you do an open repair, put a proline mesh, you can still give rise to a lot of adhesions, and it can give rise to intestinal obstruction. Inadequate overlap can also give rise to recurrences. You can see in this case, there is a lower abdominal midline scar where a good, nice mesh was kept, but that mesh was not overlapping properly. More than 5 centimeters, 6 centimeters overlap nowadays we give. So there is a recurrence on the lateral side, on the right side. Along with that, you have also seeing the umbilicus, which is not covered by the previous mesh, has given rise to a new defect. So Good surgery has been done, good mesh has been put, but it was an inadequate overlap which has given rise to a recurrence, but also not only a recurrence in the hernial scar, but there is also a new defect. So when one patient you have developed a inadequate overlap and a new defect, two hernias have recurred in this patient. And you can see I have marked this patient with a huge big mesh, 20 by 15 mesh they are going to put in this patient, which will cover the previous mesh as well as the umbilical hernia defect. So that is about the inadequate overlap. Shrinkage of mesh is also a big issue. Shrinkage of mesh occurs because of contraction of the scar tissue which forms around the mesh, and lot of meshes shrink more than 50 to 60%, and this small pores of the heavyweight meshes leads to more shrinkage due to formation of a thicker scar plate. People think that by putting a very big heavyweight mesh, the wound will hold nicely, but the small pores give rise to more scar tissue, and more scar plate will give rise to more contraction, and the mesh becomes reduced by nearly, you can see here, if you put a prolene mesh in an open repair, 75 to 94%. It can sometimes crumple and become something like a 1 to 2 centimeters mesh you will be seeing, especially in inguinal hernias. You see prolene sometimes when you do a recurrence, try to open, there is hardly any mesh there. It shrinks by more than 75%. PTFE, the shrinkage is less, it is around less than 50%. And the other meshes, the newer meshes like Ultra Pro, where there is an absorbable and non-absorbable component, the shrinkage is less than 5%. So here you can see a very nice mesh has been put, but the mesh has shrunk and has given rise to a defect at the lateral end of the mesh in this particular patient. So the macroporous meshes now have come. They give rise to good strength. They are very strong. The less foreign body load, less shrinkage in this patient. Preservation of elasticity after ingrowth is also very good. But they have a very low bridging effect, and the extent of protrusion is more, bulging is more in these patients. So if you try to put this sort of a macroporous mesh without repairing the defect, this mesh will bulge into the defect and will give rise to protrusion. Even if it is a direct inguinal hernia, you use a macroporous mesh. If it is an elderly patient, you use a macroporous mesh. For a hernia with a big defect, big hernia, direct hernia, that will bulge and will give rise to a defect which looks like a recurrence. But it is not a recurrence, but it's a pseudo recurrence. So here in this patient, you can see big divarification, nice mesh, composite mesh has been inserted, but the composite mesh is within the hernia, and because of the divarification, the mesh has become shrunken. It's a very small mesh. This mesh would have been encompassed over the divarification with closure of the divarification. So now you can see that we are doing a laparoscopic closure of the divarification, and we need to put one more big mesh in this patient to prevent another recurrence. Here you can see suprapubic area, the mesh has not been fixed properly. This is a very old video where you can see the metallic tackers have been used, but in the suprapubic area, the mesh has not been fixed, so it has folded and there is a recurrence in this patient. So how much area has to be covered? A lot of people, the beginners especially, they think that if there is a defect, he can go laparoscopically, cover that mesh with cover that defect without doing a closure, without understanding what is the size of the defect and how much area of the mesh has to be covered. So in these both pictures, you see that the defect has been just covered by a mesh. That is not enough, and you will get a huge big recurrence in these patients. So you should know how much area of the mesh has to be covered. Again, as I told you, if there is an infection or a hematoma which gets infected and you have used a drain which you have removed too early, so there can be an infection, and infection can give rise to more mesh shrinkage. Not only the mesh shrinks, even if you have used a good quality mesh, it can shrink because of an infection. And even if the patient resumes the forceful activity too early, that also can push the mesh into the defect which has not been closed properly and can give rise to a recurrence. So when you are doing a closure of a simple laparotomy or a cesarean section or a hysterectomy, can we prevent an incision hernia? A lot of people do not know. They simply close the wound and patient develops an incision hernia. So avoid large incisions by performing a minimal and invasive procedure wherever possible. And especially in cesareans and hysterectomies, consider transverse incision as an alternative to a vertical midline incision because the vertical midline incisions tend to give a larger incidence of incisional hernias than the transverse incisions. And avoid using the coagulation current of cautery when you are incising the aponeurosis. A lot of people continue to use coagulation even for the aponeurosis. Use a cutting current for incising the aponeurosis and utilize either a non-absorbable suture or a slowly absorbable suture for closure, but don't use a rapidly absorbable suture for closure of these wounds. And if it is a running closure of a vertical midline incision, maintain a good suture length to wound length ratio. It should be between 4 and 5, preferably. This point, if you understand, if you don't understand, you are likely to get more incisional hernia. Avoid excessively wide suture bites which incorporate large mass of muscle and fat. If you take a large amount of fat and muscle, what happens is this fat, it will cut through, the suture will cut through the fat, the muscle will get necrosed, your suture becomes loose and the patient will get an incision hernia. Again, avoid incisional hernia, incisional closure in the presence of excessive tissue tension. As I told you, try to operate on a subacute intestinal obstruction after reducing the abdominal distension. So if you try to operate when there is huge abdominal distension, you have to close the sutures with the tension and you will get an incisional hernia once the abdomen comes back to normal. Again, maintain adequate suture tension to coapt the facial edges. A lot of gynecologists we see, they strangulate the tissue. They take the bite and they try to pull the tissue and strangulate the tissue. Our purpose of closure, abdominal wound closure, is only approximation or coapting the fascial edges, but not strangulation. If you strangulate the edges, they will become ischemic and the patient will cut through and develop an incisional hernia. So this point one should definitely understand. A lot of people try to pull the suture and strangulate the tissue while they are closing the abdomen. This should not be done. Again, choose running suture over interrupted suture. It has been showed multiple number of times that a running suture, the incidence of incisional hernias is less than an interrupted suture. Minimize the risk of surgical wound infection. When you are operating, clean the wound thoroughly and clean the wound with saline and betadine several times if there is a contamination. Take some more time, but prevent a surgical wound infection. If you have done an abdominal wound closure in tension with all these points which I am telling you, maybe consider nowadays it is not a wrong thing to put a prophylactic mesh if you think that the patient is going to have a wound failure and is going to develop an incision. You can put a prophylactic mesh in these patients to prevent an incision. Coming to the indications for surgery in incisional hernia, if it is a patient is symptomatic or if there is a loss of domain and the defect is increasing, and if the bowel is getting into the sac, to prevent the complications, you can go in for an elective laparoscopic ventral hernia repair. But again, as I told you, prepare the patient well before you go in for surgery. There can be sometimes some semi-urgent indications like an infected mesh, a chronically infected mesh, or there can be a skin erosion and the mesh is being seen from outside. You can also sometimes have an intracutaneous fistula from the mesh. So in these cases also, prepare the patient, admit the patient 3 days before, give him good antibiotics, clean the wound thoroughly and take him up for surgery. Sometimes if it is an urgent indication for surgery like strangulation or gangrene with sepsis of the wound, then you may have to do an urgent surgery. And in these cases, when you are doing a laparoscopic surgery, sometimes you can also do a simple closure, wait for some time and do a second stage mesh implantation rather than trying to put a mesh at the time of sepsis and bowel suturing. Rather than one stage, you can convert it into 2-stage procedure. So how do you prepare your patient of an incisional hernia? CSCT abdomen is very, very important. Contrast enhanced CT scan of the abdomen has to be done, especially if you are operating on a recurrent incisional hernia, because you'll be able to analyze the size of the defect, the contents of the defect, the number of the defects, and also how the muscle is there, how the other tissues are there, whether there are any coexisting other pathologies along with the incisional hernia. All these things you have to ascertain if there is an intestinal obstruction is there, along with that. So all these things you can ascertain only if you do a CCT of the abdomen. So it is mandatory now when you operate on a recurrent hernia to do a contrast enhanced CT of the abdomen and look for all these things before you embark on laparoscopic surgery. If it is an obese patient, try to do a weight reduction, try to reduce his BMI. If there is infection, as I told you, control infection. Smoker, again, I am repeating, 3 weeks of stopping of smoking is ideal if you are operating on a patient with smoking. Optimalisation of the comorbidities like diabetes, pulmonary issues, the COPD, renal issues, and the cardiac functions have to be optimalized before you take up a patient for a surgery, because it can take a longer time, and if you are a beginner, it can be a longer duration surgery. So you need to optimalize all the comorbidities before you take up for surgery. Here again, you can see in the CT scan, if the previous mesh is there, you can actually see the mesh, how it is, the mesh has gone to one side, and how the bowel has come completely outside and is lying. Even the mesentery and the mesenteric vasculature, you can see coming and lying in the subcutaneous. You can see that there is no intestinal obstruction in this patient. So all these things you can identify in a CT scan. Again, which patient, when you are taking up, you have to tell him that he has got a risk of a recurrence. If it is an elderly patient, if it is a male, he has got a collagen issues, he is a smoker, renal failure, COPD, diabetic patients, patients on steroids, cancer patients, malnourished patients, and cirrhotic patients, you have to tell them that there is a possibility of recurrence. Patients on anticoagulation therapy, nowadays we get a lot of patients on anticoagulation therapy, post PTCA, post CABG patients, elderly patients come for incisional hernia surgeries. You have to stop the anticoagulants for 5 days before surgery, because during surgery you can have a lot of bleeding, and if you are doing a laparoscopic procedure, bleeding can cut down your life, and bleeding can give rise to infection, bleeding can give rise to a lot of complications. So it is imperative to stop anticoagulation therapy for 5 days before you embark on surgery. Meshes, you have to use only a composite mesh. You can never use a polypropylene mesh or a fluorine mesh. It has to be a combination, a composite mesh with collagen sheet or an EPTFE or polyglactin or polyglipolin, but it has to be a composite mesh. Normally, I do for all the recurrent incisional hernias, I do a diagnostic laparoscopy first, because why I do it is I explore the scar for other hernias, and if I have already done a previous mesh repair, I want to know why there is a recurrence. Is the recurrence because of a mesh shrinkage? Is the recurrence because of a mesh dislocation? What happened to the tackers which I have put in, whether the tackers have not holding to the tissue properly, whether my fixation devices are not properly done, and one important thing, again, what we will know is the previous mesh which we have put, whether their adhesions are there. If the adhesions are there, whether they are strong adhesions or whether they are very simple and easy to remove adhesions. All these things we can know. So we need to do a diagnostic laparoscopy first. And usually in recurrent incisional hernias, we do a Palmer's point pneumoperitoneum and Palmer's point entry first to identify all these things. We make a note so that we can prevent recurrences in the future. Again, normally when we do adhesiolysis, we do an adhesiolysis. When you are doing a lap chole, we do adhesions only, adhesiolysis only in the upper abdomen. When you are doing something like hysterectomy or ovarian cyst, we remove the adhesions only in that particular area. But in laparoscopic recurrent incisional hernia, adhesiolysis must cover the entire area of the previous scar, because in this previous scar, there can be Swiss cheese defects that can give rise to a recurrences. So you have to do a complete adhesiolysis, and you have to identify the possible wall defects, not only at this level, but other than those originally destined to be repaired. What you have seen plus what you can expect. So you have to completely, the whole scar area has to be adhesiolysis, has to be done. There cannot be a discount in the adhesiolysis. Here you can see the previous mesh is there. So even the mesh adhesions also have to be removed. centimeters more mesh more on all sides. That is ideal. You have to mark your defect. Again, previously we used to not to do a defect closure. Nowadays, we have to close the defect and we have to put a mesh which is 5 centimeters more on all sides to get a recurrence-free incisional hernia repair. How to fix the mesh? You have to use both full thickness abdominal wall sutures, maybe transfacial, and also point fixation devices like tackers. Both we have to use. Initially, if it is a small mesh like a 10 by 15 or a 9 by 9 mesh, you can use 2 transfacial sutures. If the mesh is larger, if it is more than 15 by 15 or if it is a 20 by 15, you have to use 5 transfacial sutures to the mesh, about 1 centimeter from the edge, and you can use rest of the absorbable tackers at the periphery, 1 centimeter apart with the triangulation using what is known as a double crown technique. I will show you what is that double crowning technique. Here you see a 20 by 15 mesh where we are using number of fixation sutures are here, 5. So the larger the mesh, the more the fixation, transfacial fixation sutures. The smaller the mesh, 2 may be enough. What is the double crowning technique of fixation is, you can see here about 1 centimeter from the periphery of the mesh, you are using tackers and they should be 1 centimeter apart with a triangulation inside, which this is known as a double crowning technique, which has to be used for fixation by tackers. How to reduce the seroma? Because seroma also can give rise to, seromas can get infected. You try to aspirate the seromas, patient gets worried and you introduce the infection and then you'll have a lot of problems and recurrences. So wherever you can excise the sac, you have to excise the sac completely. Sometimes laparoscopically, it will be very difficult to excise the sac because the sac goes on to one side where your instruments will not go and you will not be able to excise through that small laparoscopic port. Technically also, it may be very difficult to excise the sac. And if it, especially if it is a large sac with multiple cavities, you may not be able to excise. In these patients, my advice to you is make a small incision, excise the sac completely, do a hybrid repair. You can close the wound from the open repair and put the mesh through laparoscopically. This is known as a hybrid repair. This is very useful for beginners and this is very useful for large sac, difficult sac to be excised. You can give a very small incision and excise the whole sac and do what is known as a hybrid repair. Again, you can cauterize the sac. If there is bleeding, you have to control the bleeding. You can inject fibrin glue to reduce the seromas. But if you do a good hemostatic repair, your seromas will definitely be less. If you have a large sac like this, and if the bowel is adherent, you can see the bowel is gone inside, completely adherent. You try to use a bowel grasper and try to get it back, it doesn't come out. These sort of cases, my advice for you is to go for a hybrid repair where you can excise the whole sac, you can release the bowel adhesions under vision gently, perfectly. So don't think that you are a very good laparoscopic surgeon and try to do all incisional hernia repairs laparoscopically. There are indications where you can do a hybrid repair, where you put a mesh laparoscopically, but you can do a open excision of the sac, open removal of all the bowel adhesions, and closure of the defect also you can do open and then go back and put a mesh laparoscopically. So how to reduce infections? Again, you take laparoscopic ventral hernia repair as your first case in your theater. Don't do it after other cases like appendicectomy or acute cholecystitis or incisional hernias or other different cases. You do your ventral hernia case as first case and have a good imaging and proper equipment. All instruments where you are using, don't use Sidex used Sidex dipped instruments. Use all autoclaved instruments and try to prevent excessive bleeding and a hematoma. As I told you, if your patient is on anticoagulants, please stop anticoagulants for some time. And most of the patients nowadays whom we are getting patients who are under aspirin. Please stop aspirin for 5 days and then take up the case for surgery. Attain very good hemostasis. If you reduce your bleeding, your infection rates are also less. And when you are handling the glove, change your gloves. When you are handling the mesh, change your gloves. Use fresh gloves for handling the mesh. And again, before putting the mesh, you can actually, if you have done a hybrid repair, clean the abdomen again with betadine, paint the wound with betadine, and then change your drapes, and then use a fresh mesh with a fresh gloves. Your incidence of infection will definitely be low. So how to improve our results in laparoscopic ventral hernia repair? Improve teaching and improve techniques. We learn with each failure, we learn, and we teach our juniors what we have learned and what techniques which have to be used. We have to teach them. Analyzing the reasons for reoperation and the recurrences of hernias. You put in a scope, see, look why you have failed. You will analyze so that you will not do the same mistake again. Standard procedures for standard patients. Don't try to do E-tips and TRs for simple hernias. Standard procedures for standard problems. Tailored approach for non-standard problems. Identify the patients at risk for recurrences, as I told you, and tell them, explain to them that recurrence is possible. Take the help of a senior colleague. Take the help of somebody who is doing more number of incisional hernias when you are operating on patients with high risk, and treat the patient. Pharmacological and biological treatment of hernia disease also has to be done. And bioprosthetics are, maybe in the future, they may be coming in a big way, but as far as now, all the bioprosthetics also we have used, sometimes they have not been of much help. Bioprosthetics are very, very costly, but we still don't know what sort of a measures will come in future, which are going to be good for the patient and good for the surgeon. So thank you very much for giving me an opportunity to share my views on recurrences in incisional hernia and how to prevent that.
Thank you, sir, for your very brief, excellent, and informative presentations. And you have touched all the corners of the hernias for prevention. So I think every surgeons who have participate here, they can share their knowledge. They can they earn this knowledge so that use every steps for managing the hernia for preventions. Thanks a lot, sir. So I request our panelists, sir, Professor Shamsul Alam, sir. Do you have any query, or would you like to share your views? Sir, you have to unmute your microphone, sir.
Okay.
Professor Shamsul Alam, sir.
Thank you very much for having me. This has been a very comprehensive discussion on recurrence of hernia, but he has not left any point untouched. So what I want to emphasize that you have said that techniques has not changed the recurrence rate too much. But I don't buy into this this notion. I have gotten my own idea. What I have observed that for the newer techniques has, of course, reduced the number of recurrences. Newer technique, I mean the ETP and also the placement of the mesh in the retromuscular plane, retromuscular, or what is commonly known as the sublay. This is a plane where if you put the mesh, you can reduce the number of recurrences a lot. It makes a very significant difference. So in the first place, when you face with the hernia, it's more than 4 centimeter. Below 4 centimeter, IPOM is good. But during IPOM, it should be, one thing should be added, that is the fascial closure. Do you do the closure regularly, or if you just leave the mesh for a breeze? Dr. Suresh?
Suresh, sir, you have to unmute. Yeah.
Yeah, now I have been unmuted.
Yeah, okay.
Here in my series in the early 2000s, I used to do a closure only on larger defects. But now I feel I will close all the defects, even if they are less than 4 centimeters.
Yes.
I try to close the defect because for 2 reasons. One is the size of the mesh which I put now becomes smaller. If I close the wound, I can use a smaller mesh. And even if I use a larger mesh, like my point of using a larger mesh will be working on that on those places. So my idea now is to try to close all the defects, even if they are small or large. So closure of the defect will facilitate a smaller size mesh to be kept. Even if I put a larger mesh, it will be beneficial to the patient rather than trying to leave a wound, leave a defect. And
When you close the defect, you leave some tension over there, isn't it? Of course, you are leaving some some amount of tension in the fascia. So I think that if the defect is more than 4 centimeters, in those cases, the ITP or the TAPP, transperitoneal and preperitoneal approach, transperitoneal approach can be done. And if you put the mesh in the retromuscular space, that would give a far better results. And of course, another question is that if you have done the IPOM and there is recurrence, and that only preperitoneal space over this surface is not that optimized, what you have got in the first place. So in that case, I think the retromuscular placement of the mesh is far better, and we should try. We should not try a re-IPOM. What is your take on that?
Yes, sir. There's a question from the audience, sir. Recurrence after IPOM. What's your management plan?
recurrence after IPOM.
Yes, sir. That's a question from the audience.
As you have seen, one of my pictures I have shown you, I mean, 2 or 3 of my pictures I have shown you recurrence after IPOM. We can still go in and redo IPOM. I feel doing an ETEP and TR are much more dangerous in those scenarios because if there are additions of the bowel to the mesh, however, even if you use a composite mesh, there are possibilities of bowel additions to the mesh. And if you try to do an ETEP or TR in those patients, you are going into a plane where you are not seeing the bowel additions and where there is already a mesh there. So try to go to that plane. Not technically number one. Number two, if in the sac, if the bowel is adherent, or to the mesh if the bowel is adherent, that is maybe very difficult to release, and sometimes we may be injuring the bowel to try to go in that plane. So I feel if you have done an IPOM and if there is a failure, if you can do again IPOM and release the additions, it is better. Or else on hybrid method where you do a open reduction and addition, and then we insert a bigger size mesh to the laparoscopy as an IPOM. Be an ideal and better. ETEP and TR are easy to discuss, but very difficult to. I have seen a lot of senior surgeons in workshops trying to do an umbilical hernia ETEP or TR and have produced multiple tissue defects in the peritoneum, and they put a proline mesh in that area, so all the bowel can go and again get stuck because of those defects if they don't close those defects. Supramuscular area, if they put the mesh, retromuscular area, a lot of dissection if they do, the incidence of hematomas are very high. If you do
Sir, there are 2 more questions, sir. If there are multiple defects in different quadrant, how will you close the defect? And another one is the defect size is 7 centimeter. Would you go for laparoscopy or any other technique, either hybrid or open technique? There are 2 questions.
If I can do a laparoscopic closure simply and easily, I will try to do a laparoscopic closure. If laparoscopic closure is not easy, then I will do a hybrid method, especially if it is a recurrent incisional hernia. And there are a lot of additions to the mesh, additions of bowel to the sac. Then I will do a open repair hybrid.
If there's a multiple defects in different quadrant, how will assess and manage that defect?
If you have multiple, more than 2 in different quadrants of the abdomen,
And would you separately close the defect or make it one, then close the defect? What
then
would,
you can close them. I've shown you one of my picture where there is a recurrence as well as an umbilical hernia. I was able to close both with a, but if one defect is in right iliac fossa and one defect is in the upper abdomen, then maybe I may have to use 2 different meshes. Preferably, I try to use one single mesh as far as possible. But if it's physically not possible, then probably 2 different meshes is an option.
thank you, sir. Dr. Nurushan sir, sir, one participant addressed to you that if during surgery there is inadvertent injury to the bowel, would you simultaneously close the complete the surgery or go for stage procedure? What's your opinion, sir?
Thank you, Dr. Mamun, and thank you, Suresh. Really, it is a beautiful presentation, and you always. I also say I have seen your several presentations. You always tell and always present nicely. I have some comment at first. Give answer before the Mamun's question. When IPOM recurrence means always it is a complex hernia. So at that time, I create the pneumoperitoneum through the Palmer's point. Then I would assess whether it is feasible or possible to continue by the laparoscopic. If there is a severe adhesion, then I discontinue the laparoscopic procedure. Because injury is more in case of adhesion, and if the surgeons are not expert enough, and in that cases, it is better to open the procedure. Another thing is during the again same procedure, multiple pocket hernia, multiple defect. Again, we go through the Palmer's point, create the pneumoperitoneum, see the adhesion, and then decide whether we can go for laparoscopy or open.
Suresh sir, are you agree with me?
Now,
yeah, okay, sir. Go on, proceed, Dr. Nurushan sir.
Now you have to put the question: if there is an injury to the gut during the laparoscopic procedure or repair of the recurrent incision hernia, what would be the management?
Yeah.
I think in that case, again, recurrence hernia is a complex hernia. If gut injury is minimum gut injury, and gut is, as Suresh said again, you should be prepared gut well. If gut is prepared well enough, then you primary repair and go for procedure continue. If it is the gut is not prepared and there is a multiple injury to the gut, you better go to the stage procedure. The first to the injury gut, then next time to the hernia repair.
Thank you, sir. Suresh sir, are you agree with him?
Absolutely. Yes, I have actually in my presentation itself, I have told you, I do a good bowel preparation. Even if the patient comes to me with subacute intestinal obstruction, I try to take 2 to 3 days time and do a good bowel preparation. Bowel should be empty when you are doing a laparoscopic ventral hernia repair. Even if you injure, you can repair it and go ahead. But for a young surgeon, for a beginner, my advice is if you have not prepared your bowel and if there is a bowel injury, please do a staged repair. Because if you put a mesh which costs around 60,000, 70,000, you use crackers which cost you around 25, 30,000, and because of your bowel injury, there is a sepsis, you have to remove your bowel, then big mess. So my advice, and you
Sir, I'm Dr. Sir, I'm
better you do a staged repair.
Okay,
yes.
Prepare your bowel properly, and there is absolutely no leakage, and you are a very good surgeon. Yes. You are able to do a bowel closure laparoscopically. My advice is do stage procedure.
Thank you, sir. So
Yes,
that information is
Sir,
there.
I'm Dr. Krishna Mujumdar. Sir, I have one question.
Also the patient.
Yeah.
Sir, Sir, I have one question. I'm Dr. Krishna Mujumdar, sir. Thank you for your excellent presentation. But
hello.
So I think there is some problem. We cannot hear you, Dr. Krishna Mujumdar. So the information is that you have to preparation of the guard is necessary as well as depend upon the expertise of the surgeons.
About the bowel injury, I have got a point. When
Yes,
you have got a bowel injury, you must inform the relatives that they are waiting outside. You must inform them. And if
Okay,
you
yes,
postpone the operation and go for the
very,
make a date for the next week, there's no problem. You will be in the safe position. So being in the safe side is always important.
right, sir.
In my opinion, you abandon the case, inform the relatives, and schedule for the next week.
Okay, sir. That's
How to prevent
Sir,
a bowel injury is much more important than how to manage a bowel injury. As I told you, recurrences in incisional hernia, prevention is again much more important. Like that, prevention of bowel injury is very, very vital. If somebody has used a monopolar current, or if somebody has used a very blunt scissor, or if somebody has used a harmonic scalpel, then the bowel injuries you will not be able to identify. You have to use a new to release the bowel adhesions in laparoscopic ventral hernia repair. Release of adhesions in laparoscopic ventral hernia repair is a very big topic. Itself is bowel injuries in laparoscopic ventral hernia repair is itself a half-an-hour discussion topic. My advice is the new scissor and try to prevent. If you induce a bowel injury because of cautery, you'll not be able to identify on table. It will come after 2-3 days and you'll have problems. So if you have opened the bowel on the table, then that is fine. You can actually go in, repair the bowel if you are not an expert, or if you are an expert, you can repair the bowel without spillage. If there is no spillage, you can put a mesh.
Okay, sir. Thank you. Sir, one question is that what will be the optimum intra-abdominal pressure during fixation of the mesh?
Optimum?
Intra-abdominal pressure during fixation of the mesh.
Absolutely. See, when you have done it, and you have done with your transfacial sutures, maybe 2 or 4 or 5, after putting the transfacial sutures, you have to reduce the pressure. If you are usually operating on 13 or 14, make it up to 10 or 11. You reduce your pressure to 10 or 11, then you will be able to use your tackers well.
Okay, good, sir.
Sir, I have one question, sir. I'm Krishna Majumdar.
Yeah.
In a corona pandemic situation, what are the in corona positive patient, and after when corona negative, what are the protocol of management of incisional hernia repair laparoscopically?
We did have,
because the corona situation is very unpredictable and uncertain in all over the world.
Okay. Sir,
Thank
sir,
you,
please.
sir.
A very good question. In this scenario, the question is very apt. We did have in our initial phase of lockdown, we did have a obstructed incisional hernia patient. So in the initial phase, we were very much worried about the spillage of particulate material and infection and food infection. So we did an open repair and we put a onlay mesh. But I think if we are now we are doing we have a special equipment which will absorb the particulate matter. We have filters now which will absorb the particulate matters. In our hospital, the company has put up on a trial basis for 10 days. In that period, we did operate on 2 patients. So what happens is one of your trocar is connected to the machine, which will absorb the particulate matter. Even if you are using harmonic scalpel or bipolar or monopolar, we can now do laparoscopic ventral hernia repair, provided you need a machine which will absorb the particulate matter which is produced during the laparoscopic surgery. Otherwise, I can give you a small tip. You can connect one of your trocars to a chest drain, underwater seal chest bag.
Yes.
Water seal drainage.
You can put around 150 ml of 5% sodium hypochlorite solution in that. And when you are using cautery, you can connect that, open the trocar, and whatever particulate material comes, it will go from the under the sodium hypochlorite solution.
Right.
My advice is, if it is a COVID positive patient, don't operate. Even
Thank you so much.
Okay, sir. So, sir, that's the good. I think almost all the surgeons in here, they are doing laparoscopic surgery by water seal drains. So one question, Professor Shomirandan sir, would you, during fixation mesh, would you like to prefer taker fixation or intracorporeal knotting stabilization? If taker, is it absorbable or non-absorbable?
Thank you, Mamon, for your nice question, and thank you, Suresh, for your nice presentation. And you have touched all those corners.
Sir, you also give your comments, sir, regarding this.
Yeah. Firstly, I would like to answer Mamon's question. Yes, transfascial fixation is must. Whether it's five corner or 4 corner, fixation must. But you must put the tacker, because only suture cannot hold the mesh, as well as only a tacker also cannot hold the mesh. So you must put the transfascial suture, 4 or 5 suture, either 4 corner suture or 5 point suture, and then you must double crowning the tack. Preferably absorbable tack, because it's now available, so that you can use the absorbable tack, and tack must be double crowned.
Yeah.
And around the defect also.
So, is there any chance of recurrence in comparison to absorbable or non-absorbable tacker?
Rather than recurrence, I would like to say one important point, because I have faced a lot of problem regarding incisional hernia, because I did laparoscopic incisional hernia since 2005. So I have faced all those complications, whatever you have discussed over here. Okay. Because firstly, I would like to say, if you just used only transfascial closure, or the gap between the 2 tacks is mass, then when pneumoperitoneum release, then intestine will enter into the mesh as well as parietal, and so that your patient landed with intestinal obstruction. So double crowning the tack as well as transfascial closure is very important. There is no more gap you will expect. So that, and I have addressed this patient, and patient will die later on. Make it a point. So don't compromise your technique. I always said, the incisional hernia, whatever is the hernia, you will treat the patient, but God will cure. So take care of all those
That's
points.
a very informative message.
Yeah. So you expect that your whatever measure you will take, in a certain time, this patient may recur. So every effort you will apply. Okay. And one more thing, Samsul Alam sir has already been raised this issue, bowel injury. I always say that if you have encountered bowel injury during a laparoscopic incisional hernia, please go through a stress procedure. Initially repair the bowel and leave the patient, and then 1 or 2 weeks later, even though after months, you can do the mesh repair. So that stress procedure is very important.
Exactly. Thank you, sir. Sir, Suresh sir, is there any relation between tax and chronic abdominal pain? Rather go for
definitely. You may encounter, and one more
thing. That's the very
when,
problem.
Why, yes.
If IPOM, there is a chronic abdominal pain.
Now the question is raised that why we shift this IPOM to either E-tape or
exactly
TAPP. Why we shift this techniques? Because IPOM and IPOM plus is more technically easy for adapt the surgeons. But why you shift this technique to TAP or TAPP, E-tape or TAP? Because the pain is very intractable pain. If intractable pain persists more than 1 month, that means patient always nagging on the surgeons why this pain happened. So pain is very important factor for this year. So that nowadays we are just shift from the IPOM to E-tape. Yes, pain is the constant thing.
Sure, sir. How will manage these sorts of the pain? How will counseling and treat this pain, sir?
Counseling is very important. After counseling, you also.
Yeah, sir. I want to know from Professor Suresh, sir. Suresh on the side. how you will manage this chronic abdominal pain?
See, as
Sir, you have to unmute. You have to unmute your microphone.
okay,
Yeah, okay.
one should always counsel the patient that there can be some amount of pain in laparoscopic ventral hernia repair. But we have seen when you use absorbable tackers, the amount of pain is much less and it usually dissipates over a period of time. Earlier period in early 2000, 2001, 2002, we used to use metallic tackers. That used to give rise to a lot of pain. Second thing, what I have observed is, I have seen a few surgeons who use intra-abdominal suturing or too much and 5 transfacial. They are much more painful. Transfacial sutures, the pain is much more severe. And pain in transfacial sutures, my advice to younger surgeons is use Vicryl, rolling. If you use rolling for transfacial sutures, it can give rise to pain, especially if you are using it on the lateral side. If you are using it in the midline, it is okay. Transfacial sutures in the midline are not much pain. But as you laterally, my advice to you is use Vicryl, use absorbable sutures on the lateral side. Even if there is a pain, it will disappear over a period of 4 to 6 weeks or sometimes.
Thank you, sir. Sir, one question to Dr. Mozammel, sir. Sir, if there is defect in the lower abdomen, so how will fix the mesh in the inferiorly? What's your suggestion?
Thank you very much, Dr. Mamoor.
Yeah, this question arises from the participant.
In lower abdominal hernia, incision hernia, we have to first additional lysis we have to done
because here you have to be aware of the urinary bladder. So
yes, we have to additional lysis the addition and reduce the hernia, and we have to make a flap in the peritoneum and take down the parietal peritoneum and the urinary bladder and open the pubic bone and find out the pubic bone, and we have to find out the Cooper's ligament. Then we fix the mesh in the Cooper's ligament with the tackers, and then mesh is overlapped by the peritoneum and cover up by the peritoneum. I think this way we can manage the lower incision hernia, lower abdominal incision hernia.
It is almost similar to that of TAPP, yeah?
Yeah, right. And I would like to thank Dr. Surishan Hori sir, his elaborate and excellent presentation. I must congratulate him also. Thank you.
Okay, sir. I think
TAPP. Can I say something about IPOM?
Yes, sir. Of course, sir.
About IPOM, the trend is shifting away from the IPOM nowadays.
Yeah.
So there are the results of ETAP or TAPP for 2 years. The result is available now. The results are very promising. Recurrence rates are low, but at the same time, the pain, what you have been discussing here, the pain is a nagging problem. So in placing the mesh in the rectoperitoneum through TEP or TAPP, you will have a very acceptable pain level. The patient feels very comfortable. Patient can go home next day. And another point is that the composite mesh is very costly. You can put an ordinary mesh, Prolene mesh, in the rectomuscular space. So these are the advantages. That is why the people are shifting away from the IPOM. But IPOM will not be ending. Still, there is a scope for the IPOM for smaller hernias, smaller defects. The IPOM is good if the defect is closed and sufficient overlapping is there. And of course, the fixation should be meticulous. So what's your take about the future of the IPOM, Dr. Suresh?
Sir, my gut feeling is I have seen people who have been doing a lot of EARs and ETEPs in ventral hernia also. I've seen the best of the people while in operating workshops. They have produced multiple perforations in the peritoneum, and they put a Colin mesh in that area. Sir, I have an experience of seeing inguinal hernia PPT done, PPT done, Colin mesh inserted in that area. If the peritoneum is thin, I have shown one of the pictures also. Pre-peritoneal mesh Colin inserted, the whole bowel has gone there and got stuck. It was so bad that about 6-7 weeks have gone there and got stuck. The bowel behaves very badly with choline, especially if the peritoneum is thin. If there are multiple rents in the peritoneum while they are doing these procedures, the incidence of bowel adhesions are much more dangerous and difficult, and the patient dies with these problems rather than with the pain. So, ETEP and PAR, these are extensive procedures, not to be done by every surgeon. They have to be done in only centers where they do specialized work and only when indicated. They cannot be done on all sorts of hernias. Now, I feel if there is bowel which is adherent to the sac, if you try to do these endoscopic procedures where you are not visualizing the bowel, they can injure the bowel. And they will not know because they have already injured the bowel, they have pushed it down and they have put a mesh. The patient comes back after 2-3 days with peritonitis. If you do a IPOM, you will be able to visualize the bowel injury. Whereas if you go endoscopically into that retromuscular plane and try to release the adhesions, the tendency to bowel injury is also there. I want to be a safe surgeon and I want my patient not to come back with the adhesions of bowel to my mesh rather than I feel still IPOM is still pulling on. Maybe 4 or 5 years down the lane, I may be doing more ETEPs and TARs than IPOMs. But now I do more IPOMs than ETEPs and TARs.
Thank you, sir. Sir, I think we have a lot of questions is there, but one question, Professor P.K. Shah, sir, who is a very expert in minimally access surgery, who is keen interest in academic researchers and training a lot of surgeons. We are the young surgeons very grateful to sir. Sir, one question to you, sir. If patients previously done open and sublay repair, so a recurrent hernia, what are your advice for managing this patient? Sir, you have to unmute microphone. Patient develop recurrence after open sublay repair. So how will I say, what are your advice, sir?
Thank you very much, Dr. Mamun.
Sir.
I like to thanks presenter, Dr. Suresh Chandra Hori, who have given a brilliant, excellent, nice presentation for recurrent incisional hernia. And I also give the thanks my analyst and learned audience who have participated of this webinar. Before of this answering this question, I like to say something regarding the hernia. Our vision is to make some young surgeon to become a herniologist. Lot of hernia is available. Dr. Suresh Chandra Hori have already said, according to your presentation, it is so simple, it is so much so difficult. Our aim is to make a simple thing. Difficult thing should be simple. Complex thing should be make it simple for the safe for the patient and also for ourselves. This is the main intent objective. For understanding easy of the hernia, try it. 3 things is consideration. Hernia, we are considered the hernia, the external hernia only. Abdominal wall, first thing, intra-abdominal pressure, third thing, time. These 3 factors is always considered the hernia, whether the primary hernia or recurrence hernia. whatever may be the things. In abdominal wall, and we always understand the pathophysiology of the hernia disease, site, size, and the condition of the muscle, even the quality of the connective tissue. Collagen fiber, you have to think what type of collagen fiber even. Then we can come out from this problem. But what thing we remember this, for the last 200 years, all the surgeons all over the country, world, they are trying to treat the gold standard of the procedure of the hernia. Still now it is not established. One thing, the laparoscopic hernia was started 1903, but the mesh was started from the 1959. Still now, so many procedures, so many things has come down, but none can happy. But with our educate preparation of the patient is more important thing. If we fail to prepare the patient, we will fail to have the output of the operation. That is the main thing. Then regarding the wall infection, that is the recurrence hernia is a vicious cycle. Operation, wound infection, wound dehiscence, incisional hernia, got admitted hospital, then operation, then infection. Main thing, we have to cut off the cycle by prevention of the infection. Considering the prophylactic, antibiotic, control of the diabetes, and all other risk factors should be controlled precisely. Then we have to assess the site and size of the hernia. Then even evaluation up by the CT scan. Then you have to planning whatever may be the procedure. That is laparoscopic, open, hybrid, or advanced thing, robotic. But Dr. Suresh already explained, this is a multidisciplinary approach. You can have to help the other surgeons also. That's why then come to the intra-abdominal pressure. Second thing, that's why the risk factor, COPD, control properly, bladder outlet obstruction, bowel obstruction, heavy lifting, working, all this should be considered properly. Then last of all come to the time. What is the time? Recurrence after operation, after 1 year, recurrence is not seen. But 2 years, 3 years, the recurrence have come into view. That's why 3 things is more important to prevention of the recurrence of the incisional hernia. One thing, and mesh, come to the mesh. Mesh is come, I think so, physics. That is the principle, this is Pascal's law. With the application of the Pascal's law, we have to apply the mesh. That's why your question like that. If it is mesh is placed in the peritoneal stage, then after recurrence, which should be the plain one?
Yes, sir.
Should be the another plain one, not the same plain one. There,
Exactly.
as because the dissection plane is already dissected out, it will be very difficult. Then you have to go to the another plane, and you have to evaluation. If you see the diameter of the defect, it is below than 4 centimeter, 4 to 10 centimeter, or above than 10 centimeter. According to this concept and the site of the mesh and comorbidity of the patient, you have to decide which operation, which procedure, and how can you manage these things. If the defect is small, I think say you have to go to simple iPhone Plus. If there is no problem and there is no comorbidity, but it is everything you have to consider things, essence consideration. Then I have to say the last of all thing, I like to thanks all the viewers and analysts,
Obviously,
also our speaker, and I like to give the thanks my senior professors who are come here, Professor Mahmood Hassan sir, Professor Khadimul Islam sir, Professor Otiur Rahman sir, and others. I cannot see all the teachers.
Exactly,
I
sir.
like to give the thanks from my heart for participation of this thing. And last of all, say, share your knowledge for the younger people. It is the only way to be immortal for the whole thing. That's why we are trying to share our knowledge for the younger people.
Exactly, sir. Sir, we have, this is a session 1, sir. We are gradually progressing to the subsequent situations for managing the different types of techniques. Today's Suresh sir has nicely, briefly described how to prevent. That's the main motto, to prevent the hernia. Suresh sir, this is the last question because we have another more questions are here. But due to time constraint, just one question that's the very significant: how to deal with mesh infection? What's your advice?
Well, it itself is a big topic, mesh infection and prevention.
Just a brief, sir.
Yeah, we have discussed how to prevent mesh infection. I think
it is how to prevent.
We should take it up as a first.
Would you extract or salvage the salvage, sir?
How to prevent a hematoma, how to, if there is infection, how to do all that. But if in spite of doing all these things, you have a mesh infection, if it is an intra-abdominal IPOM, usually you don't get much of an infection. Usually mesh infections you see in onlay meshes.
Exactly.
Incidence of mesh infection is much higher in onlay meshes than onlay or sublay. Sublay also, again, you do a lot of dissection, a lot of bleeding. Retromuscular repair, the biggest problem is mesh infection. Because of large amount of bleeding, you are not be able to control the bleeding, and you just simply put a mesh there, it gets infected. And too much of dissection also can give rise to infection. Too many instruments going in, too many instruments coming out, a lot of dissection can give rise to infection. If it is a infection is virulent, you can actually do a drainage of the abscess and give an antibiotics and give a wash and give a trial. Try to prevent the mesh exclusion as much as possible. But if after a period of 4 to 6 weeks, you are still not able to control the mesh infection and mesh is still pouring pus, the best is to go in and take the mesh out. If it is a simple Prolene mesh and if it is an onlay mesh. Intraperitoneal meshes, now the incidences of infection have drastically come down. If you use a polypropylene sheet, never seen an infection. Now we have EPTFE meshes. You never see with EPTFE mesh. Maybe earlier we used to have PTFE meshes, then those days we used to have mesh infection. But that cases, if it is a PTFE mesh, remove the mesh as early as possible because infection is difficult to control in PTFE meshes. So now we are not getting those old PTFE meshes. We are getting the EPTFE meshes which have a very less incidence of infection.
Okay,
so I think what is the type of mesh
and
where you have. So I think that's.
Thank you very much, sir. Thank you very much. We are very glad that there are so many senior teachers are with us. Still, there was a Professor Motiur Rahman sir is there, Professor Mustaq Hasan Twin sir, Professor Shahad Hasan Sheikh sir, Dr. Abu Tahir sir, Professor Mahmoud Hasan sir is also with us. Rafiqul Salian sir was there, Imtiaz Farooq sir. There are so many surgeons are here. So I like to share a few comments. Sir, Professor Motiur Rahman sir is, I don't see in the screen. Motiur Rahman sir is here or not, I cannot sure, but I cannot see him in the screen. Sir, Professor Motiur Rahman sir.
Can I say something?
Yeah. Of course,
yeah. My profuse thanks to all the senior surgeons of Bangladesh. And in this COVID times, I pray all of them to be safe and try to, they are the jewels of the Bangladesh, and they should get over this COVID crisis and teach the younger generation and stay safe. So my request to all of them is please stay safe and bless all the youngsters in Bangladesh. Thank you very much.
Sir. Thank you, sir. Sir, we also pray for you and your family members, sir. Hopefully, we'll see you again in the next sessions. So many topics will be there. Thanks a lot, sir. Sir, I like to say, Professor Shahad Sheikh, sir, would you like to say a few words, a few comments? Professor Shahad Sheikh, sir.
Oh, thank you, Romeo. Thank you very much.
Okay.
I thought the Khadim sir is there.
Sir, I cannot see you. Sir.
Okay.
Sir,
But those
Khadim
who
sir. Okay,
are
sir.
doing the hernia surgery regularly, they should comment
Yeah,
on it.
definitely, sir. I cannot see
But
Khadim sir.
anyway, thank you very much. Thank you, Suresh, for your wonderful presentation. And I think the junior surgeon and the beginner who are interested in laparoscopic surgery, this lecture will be very helpful. And you know very well, nowadays, this I'm not doing this complicated surgery. The reason is that the patients are not coming to me. So I think, thank you for the good webinar.
Thank you, sir. Sir, Professor, I cannot see. Professor Khadim sir is here, sir. Sir, Khadim sir, do you hear me, sir?
I think sir is not here.
I cannot see the
Shahadab
screen.
sir.
Shahadab sir is here. I can see. Sir,
Kamrul Islam.
Kamrul Islam sir, and Abu Tahir sir is there.
Dr. Tuhin.
Tuhin sir, I cannot see, sir. Few hours back, I see him, but at present I cannot see in the screen, sir. Sir, Professor Shahadab sir, please say something, sir. Few views, sharing your knowledge, sir.
Unmute.
Sir, please unmute yourself. Sir, you have to unmute. Yes, sir.
Thank you very much for calling me. Actually, I had been working in general surgery for long 30 years. Yeah. After that, I have shifted to colorectal surgery. So absolutely, I am doing colorectal surgery nowadays. From the very beginning of the laparoscopic surgery, actually, I was one of the earliest laparoscopic surgery in Bangladesh. But still, I would say that I have not expanded much in this field. Open surgery or hernia repair, I have done a lot. And I'm very much glad to see many of my juniors who have surpassed me, actually. I thank them very much. And in the field of laparoscopic repair of this hernia, to be frank, that I don't have much experience in that. I cannot comment, but I'm very much grateful that Dr. Suresh has come very elaborately. He has covered all the fields. And I'm also grateful that Professor Mutiur Rahman sir is here. He was the pioneer surgeon to use this sort of the surgery, actually, to use this implant in surgery, in open procedure. And you know, there is the what Professor P.K. Shah has mentioned, the what I should say, the metamorphosis, or I'd say the change up or development of the hernia repair, and has come to this phase. And what he has said, that it has not yet come to the gold standard. It is a good thing. It is the good thing not to attain the gold standard, because you will never reach to the gold standard. That is a good thing, as because your endeavor will continue to develop. Your endeavor would continue to reach the best thing, but that thing is the best, that you will never reach the best thing, and because your endeavor will not end up to the end of the universe. That will go on. We are very happy. We are also very much thankful to Dr. Suresh, and I will be happy to see him again and to elaborate on to enlighten the surgeons of Bangladesh. Thank you very much.
Thank you, sir. Thank you, sir, for your encouraging speech. And we also see that Dr. S.M. Kamrul Akhtar, Syed Masood Reza is here, and Imtiaz Farooq sir is also here. But sir, I cannot see Professor Sir Mutiur Rahman sir or Khadim Islam sir. Shine sir, would you?
No, I think maybe there are a lot
they
of
left the program.
Yeah.
So I think we are at the end of the sessions. So thank you, everyone. I must appreciate all the participants in these sessions for and sharing their experience and knowledge to make this session more successful one. And also thanks to the RAS TV, Unilever. For Unilever is for the scientific partner is here. And finally, I said, yeah, I thanks to everyone. Process system, sir. Would you say something, sir?
I have some concluding remarks.
Yes, sir.
Recurrence of hernia, recurrence of incisional hernia. Once there is a recurrence, you cannot afford to have another recurrence. So
Right.
you have to be very careful. You have to be very careful, and you should go for a technique that is best for the recurrent hernia. So in the newer techniques are there. The one should not see one and do one approach. Should not have see one do one approach, seeing one thing in the YouTube and doing next. So it has to be the question of the training. The training is internationally. It has been said that if you do not do the 50 cases, if you don't do the 50 cases, you should not go for the complex hernias. So that is the benchmark, and we should adhere to that benchmark, and we should not take the advanced surgeries very lightly. It should be done by the experts. Thank you very much for having me in the webinar, and we look forward to seeing you all, and also Dr. Suresh in very soon in further webinars.
Exactly.
Again and again.
Yeah,
Just like it.
Sir, just a few words, final conclusion.
Thank you, Mamun, and actually many thanks to Professor P.K. Shah sir.
Exactly.
And all the panel of experts actually for arranging such a demanding topics, and recurrence always it is a troublesome for both for the patient and also for the surgeon, because every time patient go walk behind the surgeon, and he also feels sometimes some more difficulties with the pain and the recurrence, and sometimes abdomen towards the thigh. It is really harmful to the patient. So I think we'll meet again recurrently and with the recurrence hernia.
Exactly, recurrently will be. Sir, I missed one. With us, one of the best teacher and surgeons, Professor Mahmood Hassan sir. Sir, I'd like to invite you to say something about us. Sir, please unmute your microphone.
Thank you, Romeo.
Sir, thank you, sir.
For asking me to say something. I must congratulate you, the mid-level surgeons, and doing good. From 1985, I experienced hernias till now.
Exactly, sir.
So many hernias, including the recurrent hernias. Now I am working in a big hospital, 1,050 bedded hospital. They are the poor people and come to us with big abdominal, upper abdominal, midline, or lower abdominal hernias, and also recurrent hernias. I usually prefer and do the retromuscular placement of the mesh. And last 2.5 years in that big hospital, I did many recurrent hernias. And till now, in OPD, patient came. I usually do the open procedure. I do not do the laparoscopic, these big hernias, because it is not the age. It is the age of Mamun, Shonju, Romeo, like that.
Exactly,
they will do it, and I congratulate, and I will be happy. I will proud that they are doing very good. And Swaraj Hospital is a good place for learning, and teaching the junior. It's a good place. I know it. I also congratulate P.K. Shah for enthusiastic effort regarding his laparoscopic, especially hernia and others. Thank you all. Can you hear me? Can you hear me?
Yes.
Sir, yes, sir.
Thank you.
Thank you, sir.
Thank you, sir. I also give thank the Farooq Bhai. I mean Farooq Bhai ডাকি। আপনার সোসাইটিতেও আমি লাস্ট ইয়েতে পার্টিসিপেট করেছি, আপনি দেখতে পাচ্ছেন কিনা জানি না, লাস্ট আপনার হার্নিয়া সোসাইটি থেকে যেটা করছিল। থ্যাংক ইউ।
Just lastly,
thank you.
So, Shubin sir, just few comments.
Thank you, Maman, for arrange this webinar, and thank you, participant as well as Suresh, as well as P.K. Saha. Thank you very much for this webinar.
Okay. So I just conclude these sessions. Again, I must thanks and gratitude to all speakers, Suresh Chandra sir. I think say in future, very recently, we'll be together and we'll learn a lot. We'll learn more from your lecture. Thanks, sir. And this session will be concluded by the concluded speech by P.K. Shah, sir. So thank you everyone for your patience hearing.
Romeo, তোমার moderation অনেক ভালো হয়েছে and you look great.
Thank you, sir. Thank you, sir.
Thank you very much.
Thank you very much.
Last of all,
I do agree. Romeo is a good moderator. Thank you.
Thank you, sir. Thank you. It will appreciate me, sir. Thank you, sir.
Thank you very much.
And it looks
Last
good.
of all, I have a great desire to arrange such a recurrent hernia recurrently, who have already mentioned our Dr. Noor. We are recurrently faced to understand the recurrent hernia. Thank you very much. Thanks to all. Thank you.
Thank you, sir.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.